Good afternoon, everybody. I'm the Director of Research and Clinical Affairs at Spinal Balance Incorporated, and it is my pleasure to share with you a little I know about implant contamination and the subsequent risk of bioburden, biofilm, and infection to the patients undergoing implantation using spine surgery as an example. Surgical site infection after spinal fusion is a major complication that every spine surgeon aspires to prevent. Thus, prevention of infection, or in other words, prevention of sources of bioburden and biofilm in spine surgery, is a major thrust area among all of us. Recent randomized controlled trial demonstrated that SSI in spine surgery occurs at the rate of 12.7% and have been egregiously underestimated in past literature, which is largely based on retrospective data. Still, a meta-analysis of the past literature suggests a 3.8% infection rate with instrumented spine surgery, and that 3.8% translates to 38,000 people annually in the United States alone, whereas 12.7% would mean at least 100,000 people annually in the United States. In the previous slide, we saw that there exists variability in infection rates being reported in the literature. To further understand the cause of such variability, we must understand the sources that could lead to variability in identifying the exact rate of infection. These sources include patient demographics such as presence or absence of comorbidities, the patient follow-up time, which means that most studies are looking at infection immediately after surgery and don't have a long-term follow-up data. We already discussed in previous slide that type of study, such as retrospective versus prospective, and criteria for reporting all the results also results in poor estimation. And finally, the type of surgery, usually trauma and deformity patients which use a larger implant density have a higher risk of infection than degenerative cases, but it is still unknown if it's because of high implant density or excess of exposure to the implants or the patients. Just to give you an idea of actual variability, let's look at this slide. This data represents the infection rates that have been reported in literature, and there isn't a trend to this data. It's simply all over the place. Nevertheless, we have already established through meta-analysis of past literature and randomized controlled trial that the latest infection rate is between 3.8 to 12.7%. Now let's look at the cost implication of surgical site infection. The built-in cost of infection is in the range of $1,100 to $4,400 for each surgery being performed. So if 10 patients out of 100 spine surgeries contract infection, it would mean a total cost of $500K is allocated towards readmission and management of such SSI. A point to highlight here is that spinal fusion is a very common procedure around the world, which implies that even a small percentage of infection still represents a large patient population. For example, if 100,000 people in US underwent spine surgery in the year 2000 and the infection rate was 10%, that same number of patients, that is 10,000 people, can be represented by 1% infection rate if 1 million people underwent spine surgery in 2020. This means that with the rise of number of spine surgeries, we have to be more vigilant towards reducing the sources of infection. We talked about follow-up time being a source of variability in reporting infection, which in my opinion is not a true source of variability and is simply an imprecise estimation of data points. Most database or registry which track infections are extremely inaccurate in identifying the true rate of infection. Infections after spine surgery doesn't only occur immediately, and thus based on when and how it is clinically presented, post-operative infections could be divided into early onset, delay onset, and late onset infections. In addition, there are occult forms of infection which doesn't show clinical signs of a typical infection but still has biofilm-associated failure modes such as screw loosening. To further expand into types of infection, Early onset infection is identified as occurring immediately after spine surgery and constitutes around 50% of all reported infections. Most of these infections are deep SSI. Delayed onset infections are late infections occurring up to a year from the date of surgery and constitutes between 15 to 35% of all reported infections. Almost all such infections are reported to be deep infections. Late onset infection, which occurs after a period of 1 year from the surgery, were the least studied infection type due to lack of longer follow-up periods. However, the few studies that specifically looked at late onset infection reported an average occurrence of about 70 months with 2.7% infection rates. Other longer-term studies extending over 6 years also concluded 56 to 80 months as average SSI detection length with total incidence of 9.7%, which of course also includes early and delayed infections. In the last 3 slides, I talked about the known infection. Now let's look at the hidden form of infection. According to literature data, these occult infections are present in at least 10 to 30% of patients with chronic pain and are detected only during revision spine surgery. In some studies, researchers collected tissue from around the area surrounding each screw and implant for ground staining, histopathological analysis, and long cultures to identify any attribute that would indicate chronic infection. Furthermore, many of these patients with chronic pain and occult infection had hardware loosening and pseudoarthrosis. We ourselves are currently doing a similar study whose preliminary results I'll briefly share at the end of this presentation. For the research I'm presenting today on infection prevention, we are focused on protecting the implants, and I would explain you the reason. The study in this slide published in Nature have proven that a very small microbial biodoses by itself doesn't result in infection. However, when it is combined with an implant, it starts resulting in infections. This shows that the implants are the most susceptible host site for the survival and growth of bacterial species. In regards to sanitation of these spinal implants, which I already concluded that are most susceptible host site for survival and growth of bacterial species, there are 2 existing themes in past literature. One looks at the repeated reprocessing of single-use implants in the hospital, and the other looks at the exposure and type of exposure on implants during spine surgery. So the objective of our study was to identify each of these themes as possible modes of implant contamination. In contamination mode 1, we looked at the evidences on how the implants are currently reprocessed and does it result in contaminated implants. In implant contamination mode 2, we looked at the various forms of exposure of implants during live surgery and determined if they contaminate the implant. Here is the process flow of a typical repeatedly reprocessed implant tray. We randomly selected 6 pedicle screws from sterilely wrapped implant set and performed a detailed analysis using a variety of laboratory techniques such as optical microscopy, electron microscopy, energy dispersive spectroscopy, which is part of the electron microscopy, and Fourier transform infrared spectroscopy. We identified 3 types of contaminants, which were corrosion, saccharides, some kind of carbohydrate molecule of unknown origin, and soap residue mixed with fatty tissue. These were mostly present at the interfaces with low permeability, such as interface between the tulip and the shaft. Anywhere you can't inspect, but there are crevices, that's where we found them. To understand what is causing this contamination, we also reviewed several large manufacturers' implant reprocessing guidelines and compared it with what the hospital actually does. We found that if manufacturers' guidelines are followed precisely, which I mean legally, then at least 19 hours of reprocessing is required, whereas the real-time observation revealed a turnaround time of 1 hour, 17 minutes at the hospital. The red circle identified the steps that were always missing during the actual observation of reprocessing of implants, single-use implants at the hospital. This suggests that manufacturers are prescribing impractical reprocessing guidelines for SPD, which is the cleaning and sterilization department. So in conclusion, for contamination mode 1, the only solution to this problem is to use prepackaged sterile implants. In Scotland, the deadline for conversion of all orthopedic units to prepackaged sterile single-use implants was December 31st, 2007. It was pointed out by the Scottish Health Department that repeatedly reprocessing implants in the hospital is a suboptimal clinical practice, similar to what our research showed. Many countries now, such as Netherlands and Japan, are moving towards this solution. And for United States, I filed an official petition with the US FDA to do the same. Here is the process flow during spine surgery to identify the contamination mode 2. As you can see, these are loading of implant onto the driver by the scrub tech. And remember, this is all in the sterile field. So the first one is loading of the implant onto the driver by the scrub tech, who is helping the surgeon with surgical site preparation. The second one is exposure of the implants to the air inside the sterile field, and then transfer to the surgeon, who makes the final assessment of the fit of the pedicle screw before implanting into the patient. This particular study, Contamination Mode 2, was conducted in 5 US hospitals and consisted of a total of 28 spine surgeries. There were 2 groups of pedicle screws in each surgery. Both the groups were prepackaged sterile screws. So it did not have the contamination mode 1, and we started from something that was 100% sterile to begin with, and no variability. The first group had a preloaded intraoperative guard from Spinal Balance in the package, which avoided direct exposure to the 3 modes of contamination, which I described in the previous slide. And the second group had no such guard. It was simply in the sterile pack, and you open the guard and the screw is exposed in the sterile field. Here is an example of a guarded screw and how it looks like after loading onto a driver in the sterile field. Then the 2 groups of screws after exposure in the sterile field were sent for bacterial culture and analysis through spectroscopy and streaking. In spectroscopy, we grow the bacteria in the flask or whatever exposure the screw received in a flask. It's 3D. And then we measure the transparency of that fluid, which is a medium. And in streaking, we grow them on plate to identify how the colonies form. In spectroscopy, results showed that all the unguarded screws resulted in increased opacity of the growth medium, which is the liquid in the flask, showing positive growth of bacteria. In contrast, all screws with guards showed transparency in the growing medium and remained sterile for the complete period of the experiment, which is 14 days. Similarly, in streaking studies, we found that bacterial colonies were formed with unguarded screws within a period of 24 hours. However, the guarded screws showed no such appearance in colonies for the entire duration of the experiment, which was 7 days. After 7 days, your petri dish has dried up, so there is no point continuing forward. The main species identified in this study was Staphylococcus and Micrococcus, and these have been previously reported to be associated with SSI. The key takeaway from this study include that exposure in the theater results in contamination of implants, and this contamination can be easily avoided by using implant-specific guards. This data set also represents a high size effect with no risk to patients, and was performed over multiple centers. In the next few slides, I just want to touch base with few of its significance. There is an analogous study performed by Rahman et al. During posterior spinal fusion, and his team demonstrated that a significant reduction of infection occurs if gloves were changed before loading and implanting each and every pedicle screw. They reduced the infection rate from 3.35% to 0.48%. In another study performed by Erin et al., pedicle screws were intraoperatively washed again during surgery with multiple antibiotics to further disinfect them from the contamination mode 1 and 2. And when I say intraoperatively, they were washed in the sterile field. The result of this experiment was that they reduced the infection rate from 6.6% to 1%, a major change. So basically, our studies on avoiding contamination modes elucidates why these studies were able to reduce infection rates, and also prescribes a novel and easy method to avoid them without added steps or need for compliance from the hospital staff. The other thing I want to revisit is degenerative versus deformity infection rate that we previously discussed in slide number 2. We have just established that more unguarded implants mean more bacterial contamination, perhaps could be the main reason why there are higher rates of infection in long constructs where you use higher number of screws. Looking at the economic significance, the two methods of preventing contamination would reduce the cost burden of SSI and also the cost burden of reprocessing that hospital incurs. Currently, these packaged and guarded screws in United States and Japan cost the same as the standard reprocessed screws. So hospital won't be spending more money to buy our pre-packaged guarded implants compared to reprocessing them themselves. Here is the economic model breakdown of such saving. Assuming 500 spine surgeries were performed at a given center in a year and assuming a reduction of only 0.5% in the SSI rate, the total saving could be approximated to be around $250,000. In the beginning of the slides, I talked about a fourth form of infection called occult infection. In brief, clinically undiagnosed infection at the screw bone interface has lately been proposed as a common mechanism behind pedicle screw loosening. Previous studies using laboratory culture techniques only indicate the presence of bioload without any visual evidences. What we are doing now is we're using electron microscope to capture the real-time architecture of these biofilm at screw bone interface, which was not previously recorded from patients undergoing revision surgery. Here is the data, the preliminary data, which shows that 77% of pseudoarthrosis cases presented loosened explants, and 72% of these had biofilm on them. We also found that areas with biofilm tested negative for calcium phosphate, indicating no bone mineralization, whereas areas without biofilm tested positive for calcium phosphate, which is showing bone mineralization. In addition, intraoperative swabs of tissue around the screws showed no infiltration of bacterial bioload and always tested negative, thereby showing the inapplicability of swabbing in cases with intact biofilm. The pictures here shows the halo identifying the loosened implants and the same implant under electron microscope shown as ABCD, which are subsequently zoomed images, and the yellow circle shows the individual bacteria. An added consideration based on all this data is that late onset infection requires removal or replacement of implants for a successful revision surgery, and is due to the fact that bacterial species from biofilm on the implant cannot be removed during surgery, or what we call in situ irrigation. But they need a new implant if a person shows up with infection at a later date because biofilm has already formed. With this note, I would finish my presentation, and thank you for your attention.
All right. Thank you, Dr. Agarwal, for that important implant and biofilm information. We are excited to get started with the live Q&A portion. A lot of you had some great questions that came through. So I am going to, yes, absolutely. I'm going to get right into these questions. The first one that came through, how often do you find that sterile processing follows the manufacturer's instructions for use?
Okay, so never for an implant, because there are, for example, 100 to 150 pedicle screws in a tray, and no one looks through the surfaces and holes of each of them. That would disrupt the whole SPD workflow. Really practical and not at all practical. They're just putting that in the IFU. They also know that no one does it. They only put that in the IFU, so later if it's a legal proceeding, they don't get in trouble.
Next question, when vendors bring in a large amount of sterile packed implants into your facility, are they required to store them in a temperature and a humidity controlled area?
So packaging material undergoes a rigorous aging study before a manufacturer can release a validated package material. So it can really take a wide range of humidity and temperature control. I think it would fall under the hospital quality management system if they want to control or how they control it. But for metal devices, this is the case. If it's chemical or biologics, they will have a humidity and temperature control. But in case of metal, which achieves this function by mechanical means, and the packaging material, it can take a wide range of humidity and temperature. I'm not certain that, as far as I know, we have been using it, and they never asked us if they need a particular temperature or humidity control. It has because I know from the data sheet, it has a wide range of humidity and temperature control. Now, what we prescribe to ourselves, that is a different thing. So practically, it can take a lot of variation.
How aware do you believe a spine patient is to these implant issues, and how do you think they can be further informed?
Hello, can you hear me? Oh, they are not at all aware of this. I think the only way to make them aware is a widespread news coverage. I mean, that's the only thing. A surgeon won't bring them. Like, this is all what you call it, prescribed information, prescribed surgery. They won't know the ins of how it works. It's even difficult to bring a surgeon on board with this because they themselves don't do it. It's a part of the process where the implants get, dirty. And they say we have done it for hours. Infection rates are low, which is really low. In the body, they will really hear about it if they know about it. So they don't at all, otherwise this won't be happening.
Okay. In your experience, how much time does the surgical tech spend inspecting the implants for damage, corrosion, or residual bioburden prior to passing them to the surgeon?
Oh, none, because it's not in their process. They are already overloaded by being alert to what the surgeon asks next, and also helping with passing on instruments and surgical devices as the surgeon is doing surgery. So they don't really spend time. Once in a while, they may find something that's really obvious, if there is a huge speck of blood on it. But other than that, they won't really look at anything in specific. If it's really obvious to anyone, then they will look at it. Otherwise, they won't look at it.
Okay. Have you seen any difference in the contamination rates of screws versus plates?
No, I haven't really studied plates. I use screws because screws is the bread and butter of spine surgery. So I thought if I can characterize the contamination on screws, that sums up 90% of all. And I'm sure plates are getting contaminated. I just thought screws would be a better, it could exemplify the contamination better for the study.
Do you know if there's an ETA on guarded screws for the United States?
What does ETA stand for?
Estimated time of arrival.
Oh, they're already in the market by Spinal Balance. They are in the market in US, and they are in market in Japan and cleared in Europe. So they're already using it, but in small scale, because Spinal Balance is not as big as Medtronic, DePuy, or other big companies who sell these implants in bulk. And that's another reason they want to transit to packaging device slowly, because they have billions of dollars of implants in the field. So guarded screws already in the market by Spinal Balance in Japan and US. But of course, we have a very, we don't cater to all the patients, because they all are being catered by Stryker, all other big companies.
Moving forward, would you say the recommendation should be the use of prepackaged sterile implants?
Of course. Scotland did it, more than a decade ago. I just don't understand why haven't we done it yet. I think there has been a resistance from the industry because it's extra work. Or maybe they were misinformed, and every time there was a change in corporate structure, they didn't really look into it, because it's like ruffling the water. So I think this is really required, and that's why I was filed a petition with FDA saying that here is the evidence, would you do it or not? And it's been 2.5 years, and I haven't heard back. They are still reviewing the application.
Have you compared the cost of infection versus the cost of the enclosed screws?
Yeah. So the markup on these screws or implants are very high. So the cost of a guard and a package is less than 1% of the cost of the screw, and hospital doesn't pay for it. The implant manufacturer cuts down on their, extremely high level of profit margin by a little bit and provides it to them. So hospital doesn't incur any cost of getting this package screw. And second, cost of infection, one infection would cost you from $60,000, and if there is recurrence of infection, which is very common, it could cost you up to $1 million. So if you are putting a pedicle screw that's worth $1,000, for which the insurance company, for one screw, usually they put at least 4. If you put one screw that costs $1,000, you don't want to package that $1,000 in a, at the max $20 packaging to, make sure that you don't get infected. So in scheme of things, the amount of money you're giving for the entire surgery is nothing. So if the patient undergoes infection, that's we can't even compare it.
Do you think implants will be required to be prepackaged in the coming future? When do you think it will be required for facilities? I know you mentioned that you filed that petition, but is there an end in sight to when you might hear back about that?
I thought they will get back to me in 1 year, but they haven't yet. I'm really surprised. I reached out to them, and I said, the people who are very scientifically oriented, they wanted me to come and present, but then there was a pushback from some folks in FDA, and they said that, we don't want you to influence our decision, so let us review it independently. And I was really surprised, because I'm the one who filed the petition, and if you invite me to ask me questions, that's not influencing the decision, because you already know my standing on the matter. So I think there is some politics going on, but I think there is no ethical way, or there won't be any scientific reasoning to not do it, because I made it very clear using the evidence, but let's see what they do it. I'm pretty confident they have to do it. I just don't know when, because by the regulation they go in, there is no time limit to it. It just says that FDA will respond to you within 180 days, but it doesn't say that, it will reject or accept it. So they respond to you with a boilerplate email saying, oh, your thing will take more time to review, and thereafter you'll never hear back from them for next 3, 4, 5, 6, 7, 8 years until it's convenient for them to get back to you. So
okay.
I'm not sure. It will happen soon.
Not sure. Okay, so more information yet to come, perhaps. What is the correct way to handle a patient that wants to take their old implants home with them after surgery? They've paid for them. Should sterile processing sterilize the implant for them to take home?
That's an interesting question, and this happens a lot, and I think they happen. I know many patients who got their old implants back from the surgeon. I think it's all right if they don't play with it and it's housed in a chamber, but like we all know from the recent research I'm doing, there could be biofilm on them. You can sterilize them, but it may still be there. It's like a, dead tissue. It may not be active. It may be dormant, but I would say don't play with the implants. Just keep it housed in something like a glass chamber or a jar or even a pot. But I wouldn't, would not want them to play with it. What if the surface starts chipping off and there is some active material inside? So when we can't really sanitize everything, but I think if it has been processed by sterile processing department, they can take it home. Just tell them not to play with it or handle it too much.
So are prepackaged implants considered best practice for a high reliability organization?
Yeah. I mean, considered by whom? By me or by the current standards?
Great question. Do you know of any standards that speak to this, or what is your personal opinion?
No, not really. Scotland did it nationally, and Japan is trying to push for it. I know Australia, they are talking about it. But that's the whole problem. They haven't recognized it as a standard because no one has shared this problem with them. Because when we talk about SPD, we always talk about instruments, which are very important and very relevant to SPD. And implants are always in the back burner because, only the folks in SPD knows how they actually are being processed. And if anyone in SPD goes through that IFU of implant, they will know that the things they say in there are really not being done, or it's not even practical to do it if you want the workflow to actually happen in the SPD. So I guess there is this disconnect between the team. So that's why it's not a standard yet. I hope it becomes a standard soon, this and the GARD.
Okay. Is there anything sterile processing techs can do to help promote sterile packaged implants in their own facilities?
Oh yeah, tell the hospital that you don't want to be liable for cleaning it because it cannot be cleaned. You don't want to expose patient to this. So there is enough packaging facility. All these big manufacturers have enough money to package it. NuVasive just started packaging it for outside US. Can you believe it? And they're not packaging it for US as of now. So wherever there is demand, Netherlands, all these big companies like K2M before it got bought by Stryker, they have started packaging for Netherlands. What I'm saying is all these guys are also selling in Scotland, right? They are selling in Japan where packaging is now seen they see it on a positive framework. So if these companies are doing it for outside US, so if you demand to and share with them your genuine concern for the patient, and this is what is going to happen and this is the future, hospital can write a letter that we still want to carry your implants but packaged.
Okay. How many hours or days received? Let's see. How many hours or days should the implant be received in sterile processing before surgery?
For the existing one, I think because you can answer that question better, like given how overloaded the SPD workflow is. But for the one I'm talking about, it could be with the, the industrial representative, that the surgery started, he's in there and he can bring the implants. It's ready to go, correct? Because it's surgery ready. There is no pre-processing required in the hospital. And currently, whoever are using spinal balancer stuff, they just walk in the OR with whatever the surgeon wants based on pre-planning or based on sometimes the industrial representative have seen the radiograph and communicated with the surgeon. So he has the sizes in a small bag and just walks in. So there is there is no, what do you call it, a lead time that's required. It's always implant surgery ready.
All right. What is the time range in which you have seen spinal infections post-operatively? Is it days, weeks, or months? And is there a patient demographic that's more susceptible to infection?
Oh, so this was in my presentation where I talked about early onset infection, delayed onset infection, and late onset infection. So it could be from days to years. And that's the part the patient is not educated on. They say, okay, if you don't get infected in the next 60 days, you are on the clear. But they are not on the clear. They can get infection after 1 year, after 2 years, after 3 years, because they can lie dormant in these implants. And these papers are being published every day. Just recently, someone, I know because they cited my study, and they published it from Europe saying that, these patients come for revision surgery, and we find loosening, and there is this contamination. And if loosening doesn't happen, that results in late onset infection and delayed onset infection. So it can happen anytime, and that's the scary part. Like, there is no time limit where you can tell a patient you're on the clear.
An important piece to remember for sure. Have you received any feedback? The answer to this is no. Received any feedback from the FDA regarding your proposal? Okay. Hopefully that's soon to come for you. Do you believe that the manufacturer stands to make more money by keeping implants in the instrument set rather than moving to single packaged implants?
That's a very good question. In my opinion, they don't make more money. They make more money by reducing the number of inventory, and they can only reduce the number of inventory by packaging it. So you see, they will have more cash flow on a corporate level to do more business and do more research and, have a good turnaround. So they are actually not making more money by keeping the implant in the instrument set. It's just a resistance to change because it's a change. If they had started by packaging when the whole spine surgery and implant use in spine surgery started long ago, this would have been fine. But you see, it's a change that's daunting for them. So they don't make more money by keeping implants and instrument trained. So even they don't benefit.
All right. What's the process of those hardware removals that the patient takes home? Is it still the same sterilization time? Lots of questions coming through about take-home implants.
I'm telling you, if they want to take these implants home, there will still be foreign bodies on these implants, especially when they actually have been, let's use the word, incubated in their own body for so long with contaminants. Like, how can you really clean them? But you can really make them disinfected enough. And SPD is expert to know how to do it with temperature and rigorous cleaning. So they can figure it out how to disinfect it enough. So outside the body, they don't cause any problem. And that's why I said, don't let them, expose themselves to it, like touching it and then using the same, I don't want them to put their hands in their mouth while eating after they have touched it. So rather wash your hands, even if it has been sterilized. So they can still take it home, I think, because it's not in their body, it's outside.
Okay. In your knowledge, have there been additional studies done?
Lindsay, I would still not recommend them taking the ones that had MRSA or something, because I don't know how that can, create a cascade of events. So if it's an outgrown infection, I would never recommend a patient. We already know that not all infections are detected, but at least where they are detected, not to take them home.
Great advice. In your knowledge, have there been additional studies done like this on ortho cases?
You mean looking at the contamination on the devices?
Yes.
So they haven't done the first one. They have done the second one where they looked at how soon the glove gets contaminated. Or at least I haven't seen. There might be somewhere that I haven't seen. I haven't seen the first one where they looked at at least in the journals that I read, top 5, I haven't seen them. But but you can always find good stuff in other journals also. So I haven't read them. But the second one I've seen where they have shown that the glove starts getting contaminated after, after the time has passed. So you put on a glove and then after 1 minute, 2 minutes, the glove starts getting contaminated. That study they have done. So that can be translated to the second part of contamination in the sterile field, which is, it doesn't matter which implant it is because it's coming from the glove, air, and the surfaces.
Have you seen in your work specific instructions for use for reprocessing explants?
Could you repeat that again? I'm sorry.
Yep. So any implants that a surgical patient wants to take home, have you in your work seen any instructions for use for safely reprocessing those?
No, I don't think there's a process like that. Yeah, that's too much liability for anyone to attest. I don't know if hospital does that, but I'm 100% certain that manufacturers don't do that.
Does your organization provide any parameters for, and I'm assuming the answer to this is no also, but does your organization provide sterilization parameters for implants for surgical patients to take home?
No.
All right, wonderful. If anyone else has an additional question to submit, we do have a couple more minutes remaining. Dr. Agarwal, is there anything additional that you would like to add to the folks who have asked questions up until this point, or any specific takeaways that you want the audience to remember?
I did remember someone asked about how to go about sharing this information with the hospital administration and encouraging them to use the package implant. So if someone wants to do that, at least in the United States, I'm happy to collaborate. I'm indirectly affiliated with another company which started packaging when we realized packaging will be a big thing in the United States and every device company will need packaging. I don't know if you already know, Lindsay. It's called Guardian Medical USA.
Okay.
And they have these packaging that Spinal Balance is using. They have these interesting tubes, and I'm saying they could be a good source to at least have conversation with when you have made it clear to the administration that you would like it. So I just want you to know that there are lots of companies like that, but at least one company I know very well where, I can get them to send you information when you need it. It's called Guardian Medical.
Wonderful. Okay. And just so everybody knows, Dr. Aakash Agarwal's contact info is on the speaker bios engagement tool right on your screen. So if you do want to reach out to him directly, please feel free to do so. If you would like to share this presentation with your colleagues, with your administrators, with other departments throughout your facility, like all the sessions in today's conference, this will be available on demand. So these learning tools, this education can be beneficial when you have those difficult but important conversations within your facility.
I do see a question from someone: if we bombard our state reps with this information, will it still help push the FDA to respond? My answer is yes to that.
Okay, wonderful. So anyone who would like to take an active approach in helping push this mission forward, bombard your state reps, as this person so candidly put it, and hopefully help push the FDA to respond to Dr. Agarwal's submission. Wonderful. And there was another question that came in. As part of your research, did you look at point-of-use cleaning post-procedure?
Oh, I haven't looked at it. That's a very good question. Because implants are kept separately, right? And they are legally not allowed to put in the implants back in the tray. But for instruments, I've seen that they just lie there for, next 3 hours after they have used it. So I know people are looking into having it dipped in some kind of solution immediately after they have been used and not waiting for hours, and I think that would be great. But my research has not been on that.
Right, wonderful. And Dr. Agarwal, anything additional you would like to add before we bid folks adieu this morning and transfer them into the next session?
No. I think this was a great session. I really enjoyed, listening to the questions and trying to answer them. Very interesting.
Wonderful. Well, thank you so much for all the work that you're doing. And now we know that we can all help with this mission towards single-use sterilized implants. So wonderful. If anyone has
Beyond Clean.
Absolutely. Thank you so much for being a part of our conference. Folks, we do have some additional time, so you'll get just an extra break in between this session and the next. As a reminder, after each session ends, you will automatically be redirected to the following session if you simply keep your browser window open. If you see a registration page, you can certainly click on Already Registered to simply enter your email address to access the next session if you are already registered for that session. Usually there's a 15-minute break. You'll get an extra couple minutes. Grab a snack, grab an extra cup of coffee, and the next session we will hear from a hospital patient who has lived through a periprosthetic implant infection. You're not going to want to miss this one. We'll see you all at 10:30 a.m. Eastern Time.